I am Jenny Powell. I have had a cash pay membership-based practice for 5 years. We celebrated our 5-year anniversary on March 1st of this year, and we're located at the Lake of the Ozarks in the heart of Missouri. And I would like to say that I have indeed thrived and not just survived. And a lot of that is thanks to AAPS. If those of you who either are looking to start a cash pay practice or already have, you should congratulate yourself because you are here. And that's one of the first steps. I want to talk briefly to you today about some expensive mistakes to avoid when you're starting your cash pay practice, regardless of your specialty. Because this is the voice of experience, I want you to avoid some of the costly mistakes that I made. This is a little bit about me, and I thank you for that introduction. The only reason I want to point this out is when I first went to college out of high school, I wanted to be a magazine editor. And after a year of that, I decided that was not what I was supposed to do for a living, and I quit, got married, had children. I've had some people call me a second career physician, but I don't know that being a homemaker and a sometime bank teller is really a first career or not. So I like to point out that when I was 30 and called to become a physician, I went back and I was 34 when I got that Bachelor's of Science, 38 when I graduated from medical school, and at age 41 when I completed residency. It was the same year my oldest graduated from high school. Needless to say, neither of my children are in medicine. Then for the next 4 years, I served for a Catholic organization in a small town in the middle of Illinois. And then my husband and I made the best decision we ever made and moved to the great state of Missouri. Then I worked for another Catholic organization for 6.5 years and became more and more frustrated at the interference between myself and my patients. And that's why I started the practice that I am now enjoying. So I want to talk to you about a few things, but the topics that we're going to cover: expensive EMR, expensive lease. I want to talk a little bit about board recertification and maintenance of certification, and then if we have time, I'll talk to you a little bit about expensive services. So we'll start out with the EMR, the electronic medical record. Now you have to understand, when I started this, I didn't have a model. I didn't know of anybody else who was doing this. I had just thought, hey, wouldn't it be cool to have a concierge-like practice, but affordable for just about anybody? And so I really wasn't sure what to do, whether to even have an EMR, though I had been brainwashed enough to think that I did need to have one. And so I didn't do a whole lot of shopping around. All I did was I talked to a friend of mine who was an independent physician who said, oh, I love my EMR. I think this is a great program. I think you can build it from however you want it. And I don't know if he got some kind of kickback, because that's all the advice I took. And so I contacted these folks, and they said, oh, yes, you build the program. It'll be great. You can. And I said, you guys understand I'm not billing insurance. Yes, this'll be great. But it was an EMR that most people do bill insurance, and it was designed for the meaningless use. And so it had all the typical hard stops. And it wasn't on a cloud. I had to use it on a laptop or a PC that I had downloaded the program on. And I'm on call 24 hours a day, 7 days a week, 365 days a year for over 5 years. This is not really a great thing to try to have to drive around to Panera to prescribe medication for somebody who's got a UTI. So it wasn't exactly all that, I guess I'd like to say. And then, of course, the biggest problem was it was expensive. First of all, I had to put about $2,000 or $3,000 down on on this program, and then I signed a lease for 5 years, the cost of which was about, I'll tell you exactly, it was $1,027 every month. And then I had to have a trainer come and train me, who had supposedly built this program, and my staff on how to use it. I had to pay for his time. I had to reimburse all of his travel and everything. And then, okay, we're tooling along. We're trying to make sense of this thing and trying to use it, even though it was big and burdensome. And then my year anniversary comes up, and I get a bill for $7,000. And I said, well, what's this for? I'm paying you $1,000 a month. Oh, well, this is for subscription costs, your yearly subscription costs that you have to pay. And I said, let me see this itemized bill. And they were billing me for a mid-level. I didn't have a mid-level. Are you kidding? I barely paid myself. And I had to pay for codes. I said, folks, no, I don't use codes, right? I don't bill. Why do I have to pay for all these codes? Oh, that's a requirement. If you're going to use our EMR, you have to use, and they said EHR, Tamsin, I call it EMR. You have to pay for the codes. I don't need a drug interaction program. I can get one free on the internet. But no, I had to pay for all these kinds of things. I finally said, this is crazy. I'm not going to renew with you. And I sent my lease to my business attorney to look over, and I said, hey, can you help me get out of this 5-year lease? It's only been about a year. And he looked it over and said, I'm sorry, unless you pay the complete total of what that's worth, that's the only way you can get out of that lease. So last November, I paid my last payment to an EMR that I only used for 13 months, and I added all that stuff up, and it only cost me about $75,000. So learn from me, please. My solution, I went to an AAPS meeting and heard about an EMR that is designed and used only by cash pay practices. Now, I'm trying to keep this commercial free, so I'm not going to give any names of any of these businesses, but I'm sure if during the question and answer period, if anybody asks, I'd be happy and free to tell you. But this EMR is absolutely what I need. It was designed by physicians who have DPC practices, and it is truly portable. Right now, if after I'm done talking, if I have a patient text me who does have a UTI, I can get onto her chart on my smartphone, and I can see what allergies she has. I can see what other medications she has. I can see whether I should give her that Bactrim or Levaquin, or nope, she's on Coumadin. I guess I shouldn't do that. And I can also then fax the prescription to her pharmacy in Osage Beach, Missouri, from Atlanta, Georgia. That's very important for a DPC doc. So the other thing I like about it, there's no hard stops. That's one of the best things about this program. One of the worst things about this program, the EMR, is that it has no hard stops. Nobody understood that? Okay. Because I tend to type as people talk, and I love it because I can touch type, and it really freaks out the adolescents when you're sitting there looking them in the eye and you're typing everything that they say. But then I kind of then drift off, and if I forget to finish my note, there's an incomplete note in my EMR. Another reason why I like this EMR, there is no insurance companies or governmental agencies that bill through this system, so they have no backdoor access to the patient chart. Do you understand what I am saying? One of my favorite stories of something that happened at our office was one of my staff members had got a phone call from an insurance company who wanted a copy of the patient's records, and Krista says, well, we'll need a signed record release from the patient. And the lady said, oh, no, you don't. We're her insurance company. And Krista said, well, we don't bill insurance. And the lady said, what? Well, that's not good. That's not good at all. Krista says, we happen to think it's very good. Thank you. She had to get a written record release for them to have. And when we do have that, we have a patient that says, even my attorney wants these records. We're like, what do you want them to have? And then the other thing about this is this program, help is exceedingly accessible. It's as easy as texting or emailing the physician, and you get a prompt answer. And if he can't answer it, he has his staff get in contact with you. And then, of course, the best thing is it's only $300 per prescriber per month. Per prescriber per month for this program. So let me get to Lease. When I was starting this practice, I had an idea in my head of what I wanted my place to look like. I wanted a nice, secure place for patients and for employees. I wanted the patients to have a nice place to belong. I went through this I got a really expensive lease because I had a champagne taste, in other words. And build out was one of the biggest problems for me. It cost me a lot of money. And so I have some suggestions for you to learn from me with the lease. Shop around. Don't be afraid. You can't always get what you want, but you'll get what you need, right? And if you have to have some build-out costs, it's going to be best to try to find an office that was formerly of a physician, and particularly of the same kind of practice that you have. And then your build-out is probably going to be nominal, if any at all. And never, ever, ever, learn from me, never sign a lease without your attorney's help. Okay, I wanted to get to board recertification and maintenance of certification. A few years ago, AAPS had sent out a request of its members to let them know how much it cost, estimation, to recertify during the recertification period. And I thought this was, I have no idea. I think I'll go back and look and see how much it cost for between those 7 years of my last certification. And I was absolutely shocked. It came up to about $10,000 for me to recertify with the American Board of Family Medicine. And this was before I was even attempting to do any of the maintenance of certification. And I thought, my goodness. And at that point, I was working on the maintenance of certification, and it made me rethink it. The other problem with board recertification for me is time is money, particularly in a 24-hour, 7-day-a-week, 365-day-a-year on-call for your patients. How much time it consumed away from my patients in order to do maintenance of certification or recertification. And then I realized with this type of practice that it was absolutely needless. I have no insurance contracts. I have no hospital privileges. This was of absolutely no benefit to my patients at all. And if you say, but you got some good CME, I can get a lot cheaper CME for my folks. It was also largely irrelevant to my practice. If it was so relevant to my practice, why do I have to take a refresher course? And then there was the point that I learned that American Board of Family Medicine and all of your specialty boards have banded together. These are private organizations that have banded together that have as one of their ultimate goals national licensure. Now, I'm a states' rights girl. I believe very much that physician licensure belongs to the states. And there's some very good reasons why my husband and I moved from the state of Illinois to the state of Missouri. And the fact that Missouri was a much nicer place to practice medicine was just one of them. So I have a huge problem with private organizations attempting to control physicians and your lives. So the bottom line was, for me, that board recertification and maintenance of certification are just not good investments for my patients' money. Because 100% of the money my practice makes comes from the patient. It is my responsibility to be a good steward with their money. And I look at everything now as, is this going to benefit my patient? Is this worth their investment? And I could say absolutely positively, no. While the state of Missouri does not require board certification for licensure, every year when I renew my license, there's a question on the application. Are you board certified? So before I let my ABFM certification lapse, I learned about this National Board of Physicians and Surgeons. You're going to laugh. Guess where? It was at an AAPS meeting that I learned about the National Board of Physicians and Surgeons. And so I became certified through them before I let my ABFM lapse. And here is their website. Is it costly? For MDs, the initial certification is $169. For recertification, it's $145. For DOs, it's $189 and $165 respectively. And it is for a 2-year certification. There's no examinations to take. And they require a certain amount of CME, which is what my state licensure requires as well. Before I conclude, I wanted to touch briefly on some of expensive services. This is not so much how your business can save money. It's more how you can save money for your patients. Which, as I touched on, this is what we do. I really enjoy saving money for my patients. It's a lot of fun. And, of course, when I was first starting, I just thought everybody was going to grasp what I was doing, and they would all be on board, and they would all think this was great. And so the first lady that I talked to from a lab was like, oh, yes, we've got some very good cash prices for your patients. This will be good. And so that's what we were doing. And I just, whatever it cost from the lab is what we passed on to the patient. And that was fine until about a year later when a fellow from another lab comes in and says, what are you charging your cash pay patients for that CMP? And I told him, and he could cut that in half. And so it goes. So I went with that lab. And the first lady comes back to me, and she said, well, why didn't you let us counteroffer? And I said, because I expect you to give me your bottom dollar. These are for our patients. That wasn't too cool. I'm on my 4th drug screen company, and I think I have finally found the one that is absolutely not going to charge my patients anything if they have insurance that covers the drug screen, or if they don't. So if they do, they will bill the insurance company for the patient. If they do not have insurance, the drug screen is free. So it will never cost them anything. Biopsies, I also found, because I do some skin biopsies, I found a great place where it's like $60, $69 for a skin biopsy. And it's just excellent. So this is one of the things that I have tried to do, is try to find the best price using independent imaging centers. We can't get 300, but we thought 700 is pretty good for cash price. I mean, I have folks who do have insurance who said, I think I'd rather pay the cash price than pay my copay for this. Supplies, medical supplies, if you can try to find the best price for all of that. For medications, back to what Phil was talking to you about earlier, if your state allows you to dispense non-controlled generic medications out of your office, for goodness sake, do it. At first, when we started to do this, I thought, well, $4, the Walmart $4 list, that's not much for people to ask, to pay, until I found out that we could get them 90 days of their medication. That's the same thing on the Walmart $4 list for less than $4. So you can get 3 times the amount of medication for less than what you would for the cash price at Walmart. Are you following this? And to me, then it was immoral not to pass the savings on to my patients, particularly, our diabetics or our older patients who may have more medications. You can save them almost the cost of their membership that way. Vaccines, we don't have very many vaccines in our office because they're quite expensive. They have short shelf life, and it just doesn't benefit my patients to have that stuff sitting around. So my solution for you for expensive services: take advantage of the free market, get bids, let them all know that they're bidding against each other, that you're going to go with the lowest price that you can, and try to negotiate to get it down as low as you possibly can for your patients. Talk to other cash pay practices. See what they are doing. And dispense medications in the office and utilize health department or pharmacies as far as the vaccines are concerned. And I thank you for your attention.